So when we're talking about cross-sectional imaging and CT scans, this is a CT of the abdomen and pelvis. And when you do an abdomen and pelvis CT, I typically do abdomen and pelvis together unless there's a reason you're doing just the abdomen. Because there is really no good cutoff between the abdomen and the pelvis. The iliac crest is the radiographic cutoff that they use, but the organs cross, right? Your intestines go all over, the kidneys cross that barrier. So the thing that people look at is you might do an abdomen if you're purely looking at the liver, for example, or you might do a pelvis if you're just looking at the uterus. If it's a distinct polar organ. Otherwise, particularly if you're doing it for pain or an unknown diagnosis, then you'll just do an abdomen and pelvis. When you do an abdomen, then the start has to be up in the chest because you need to include the entirety of the diaphragm because the abdominal cavity goes up to the dome of the diaphragm. So in order to include all of that, they start in the mid-chest. Here, what you see is them starting up high. So by tradition, when you look at cross-sectional imaging, this is a cross-section of the patient, assuming that the patient's lying supine on the bed, and what you can see here is that's the actual bed, right? And there's the cushion and stuff. This is the bed, and the patient's lying on their back, presented to you with their stomach up. Okay, and the classic orientation is heads away and feet is towards you. Okay, so this becomes then the left side, this becomes the right side. Every once in a while, the radiology tech will orient it for you with an A for anterior or an R for right, so you can help orient yourself. Sometimes they put it in backwards because it's a preset in the machine, and if they put the patient on the table the opposite of the way the machine was assuming the patient is laying down, then the R will be over here. The patient's image might be flipped, and the R would be on the right, but the patient's left is on that side. So you have to look at the image and figure out if it matches up or not. And that's traditionally the way it's done. What you see is really dark spots that are black, have the lowest density. Okay, so here, what would be this really dark spot? Which lung? And this is right lung. Things that are super bright and white have the highest density. So what would be this? Vertebral body. Right? And these other ones, ribs. Right? Each one is a separate rib because your ribs aren't exactly horizontal. They're oblique, so they come in and out of each image. And soft tissue is some form of gray. So if you have fat is usually a darker gray. Muscle is a little bit brighter. You can see some muscles here and some fat here. There's some thick skin here, thin skin there. And you've got your intercostal muscles here. Okay. So, what is this organ here? What do you think it's made of? Muscle. Good. What do you think it is? The heart. The heart, that's right. What is this? Aorta. Descending what? Descending thoracic. Yeah. Good. And this is we're at the level of the heart. So the vena cava is inferior to the heart, right? Pulmonary. It's got air in it, no? Esophagus. Esophagus. And this thing back here, right next to the aorta on the spine. Yes. Esophagus. So here you could see something going into that. What would that be? No, this is just a vertebral vein. And you can actually see vertebral arteries come off of the aorta every once in a while. Okay. This is a non-contrast, there's no IV contrast, so you can see the vasculature well lit up.
So you're moving down currently.
So right, this is as high as the image. And when you look at this, you have the option to change windows, okay? And there's default windows. What that does is it adjusts contrast and opacity. You can also manually change contrast and stuff, but doing the windows helps get predefined levels of things. When you do this, you get a better view of the lung tissue if you put on a lung window, but you don't get a good view of anything else because it just gets washed out. So here, what do you see? What are these dark spots? Bronchioles. Bronchi, right? These are bronchial branches. Okay, and what are these white bright spots? The vessels. You can't tell if they're arteries or veins right now, but that's the pulmonary vasculature. And then the rest of it is the parenchyma of the lung. So, it's made of the soft tissue. So, as you see, this unfortunately doesn't go high enough to get the pulmonary hilum in the picture or the trachea. The trachea is already bifurcated here. It's a little bit higher up, but when you do see it, it's in front of the esophagus. Okay, so we'll follow this. What is this part of the part? I heard all four chambers. One of you is correct. It is the right atrium, yes. It's posterior, right? And it comes, this is the cava coming into it. Okay. What is this part? Ventricle? Yes. And the right ventricle is in the front, and then the left atrium is higher up, and I can't get to it. It's here. It's going to be just above this. Okay, so as we go down, you start to see something here. What is this? Good. What is this over here? Excellent. Here's a better view of it. There's the spleen. There's the liver. What is this line here? Diaphragm. I'll follow it all the way around for you. That is the diaphragm. Good. And
Is there air in between them?
here? No, here.
Black. Yeah, right.
This is actually gray, and it's fat. There should not be any air in the abdominal cavity except within the lumen of the GI tract. Okay. If there is, that's called free air, although historically that's proven to be very expensive. Okay. So what is this part of the diaphragm called? Crura. That's right. And as you come up, you can see what is this organ again? It's called the esophagus. And this.
Can you tell that because the air in the.
Well, I know one, it's in front of the aorta here.
Sorry, if you fall, you recognize the number already, right? Just put it on there. If you fall, just put it on there.
So you can see here, it's in front of the aorta as it comes through. And there's only two things, there's aorta and esophagus at this section. If you go higher up, you can see it's to the right of the aorta. And so this is why the very distal part of the esophagus is best approached on the left, the rest is best, the other 2/3 is best approached on the right, and then the cervical aorta, esophagus is best approached on the left side of the neck, because it's, the trachea is a little to the right of it. But in the upper thorax, the aorta is to the left of it, and so the esophagus is more to the right of the aorta.
It's the same the best approach surgically.
If you need to get to it, yes, surgically.
Can you go over that again one more time?
Yeah. So the esophagus in the neck is more to the left of midline. Okay, it's to the left of the spine and the trachea. In the upper chest, it's on the right. Okay. And then in the distal, right before it crosses over, it's again on the left. Because to the right of it is the IVC. And up in the upper chest, the aorta is to the left of the esophagus. So it's harder to get to the esophagus from the left side. And in the neck, the trachea and the spine are to the right of it. It's harder to get to. That makes sense? Yeah. So it's not perfectly midline all the time. It sort of has to deal with what's there. And you can see it crosses over through this opening in the diaphragm, which is called what? It's the opening in the diaphragm where the esophagus goes through. Hiatus. Which hiatus? Perfect. Esophageal hiatus, right? So, what spinal level is the esophageal hiatus?
Yeah, something like 10.
And what level is the aorta's hiatus? And what level is the IVC? Okay, good. So you saw that here. The IVC crosses much higher up, and then crosses the goose, and then crosses the aorta. You see that, right? Good. So that's one way to help figure out your spine. Now, as we follow this esophagus, what is this organ that it attaches to? Yes, the esophagus always attaches to the stomach unless it's surgically abnormal. So that is all stomach. This thickening here, which looks like a ring kind of. Pylorus, excellent. And the pylorus typically is midline. Okay. It's a good landmark to know because if you ever put an NG tube in and you get an AP x-ray, and the tip of the NG tube goes to the patient's right of midline, it's probably past the pylorus. And so you're going to get a lot of bile and high output because it's in the wrong place. It's now nasal duodenal tube. Okay, so easy way to remember that landmark. Usually it's at the midline. And then this is the, then, which portion? So it's pylorus, and so this is easy. The duodenum portions are numbered 1, 2, 3, 4. This is the first portion. Because the surgeons who name these things are really creative. Okay. And then the second portion, so the first portion is basically from the pylorus to the first bend, which is where the ampulla is. The second portion is the straight part that goes down to the curve. The third portion is where it starts to turn around, and the fourth portion is from the turn all the way to the ligament tract. Okay, and it looks basically like a C if you look at it on the APV. Okay. So this is the liver still. What is this organ here? Gallbladder. That's right. And the gallbladder connects to this system here. What is that? Bile duct. Which more specifically is probably the common bile duct here. What is this? And I will tell you it's a vessel. It's hard to see, but it's a vessel going here. It is a vein. Which vein? Not duct, I said it's a vein. It's the portal. And see, this is the portal. And the IVC is here. So, you know what the hepatic vein is?
Is that one up past the the side of the liver?
The hepatic veins go from the liver to the IVC. They drain the liver. Whereas the portal veins are actually inflow into the liver. You can't see it very well here, but off of this aortic branch, you'll get a hepatic artery, which runs alongside here. And I can't really make it out because there's no contrast. It's all fuzzy. What is this organ here? Right. What is this organ here? No, this is the spleen. This is this thing I'm talking about. Not small. Large.
Is it the
This is the splenic flexure. So what? Splenic flexure of the colon. Excellent. Good. Right? Spleen. Boom. Stuck together. So let's go back.
It's not him.
So let's go back up. And if you see, this is the first anterior branch off of the aorta as you get to the bone. As you're going down, this is the first anterior branch of the aorta. What vessel is this?
Is Mr. Zarabi? Help me.
So,
he's busy right now. Can I
From
take
the
a
chest down into the belly, and this is the first anterior branch off of the aorta.
It's
I'm
not
sorry.
the
I understand.
Cilia. Cephalic is the name you use it for cardiac bypass. Celiac trunk. Okay, good. And the celiac gives you this vessel, splenic artery, right? And if you see it here,
Which
then it's a
medication?
branching. You can't see it very well because there's a lack of contrast here.
Give me one
Sorry.
second.
And it gives you another branch. Well, it gives you the gastric and the common hepatic, and then
When did he prescribe
common
it?
hepatic gives you the gastric, and then it becomes the proper hepatic artery. Right?
Give
And
me
also
one
and
second,
then
I'll
the
put the jump
gastroduodenal and pancreatic duodenal branches. Okay, those are further. Good. Now we follow this aorta down more, and there's another branch. What is this one? SMA. Perfect. Right after that, I see something crossing over. What is this?
It looks like a mini pancreas.
It is not the pancreas or a mini pancreas. So remember this structure here. This is which renal vein? Left renal vein. Perfect. The left renal vein, remember, crosses in front of the aorta, just under the SMA. And the right renal vein is very short. Okay, go back up. What is this structure here? And this one? Right. Good. If I come up here and I show you this sort of Y-shaped haziness here in the fat next to the top of this kidney, what would you call that? Yes, that's the right adrenal gland. And you would have another one right over here. Sort of looks like an upside down Y.
Can you show us the first one again? Sorry.
It's upside down. 1, 2, and then straight over. When you have contrast, it's a little easier to see it. But it's this hazy upside down V or Y shape. And you can see that here as well. And those are the adrenal glands. That's a normal looking adrenal gland. When the adrenal glands have a growth or a mass, then you would see a roundness there. Alright. So, what is next? So if you look here, what do you see going across in the front here?
Is that the transverse colon?
Yes.
Oh, large.
Yes. So you can kind of see the hostra, you see a little bit of stool and air, right? Uh-oh. There you go. Okay, it's frozen. So let's come down a little more. And as you go down here, you can see, look at this midline. And then you see this, what is this?
The rectus abdominis muscle.
The rectus, that's right. You can actually see the posterior and anterior rectus sheath. Okay, so when there's, you can look at this and see it's continuous all the way through, so he doesn't have a hernia. Okay, let's keep going down. We'll look at what looks to be over here. Looking for something, a good view of it.
It's a pretty round shaped person. I've noticed it's really round. Not the back.
He's pretty fit. You can see, okay, so here, this is a good view. You can see the rectus, right? Do you see this here? What is that? It's the posterior rectus sheath. The anterior rectus sheath is here. You can actually see it's coming together here, right? This little V. So you remember learning in anatomy what forms the posterior rectus sheath above the umbilicus? Yes. And the posterior layer of the internal oblique. And the anterior layer of the internal oblique and the external oblique form the anterior sheath. So you can actually see the internal oblique split into two pieces that help form the anterior and posterior rectus sheath. And then, so this is external oblique. He's actually very muscular, internal and transversus. Okay.
So if it was fat, it would be more darker.
Fat is like this. This is fat. This is all. This is fat. This is fat. Okay. So go back up and you see this organ here. What is this? I'll follow it for you. Comes over here. Comes over here. This is the ascending colon. This is the hepatic flexure of the ascending colon, and then going to the transverse colon here and coming across, right? And you come down. We're going to follow this down to where it ends. So it ends right there, huh? So what is this? Cecum. Good. This is small intestine. All of these are small intestine. This is probably sigmoid. Yes. Okay, so descending colon comes to form sigmoid. It's going to come around. Oops, that's too fast. Comes around, gives you the rectum. Okay. The rectum, there's the sigmoid and descending colon. Okay?
Do you have inflammation at any of those sites?
Uh-huh.
Similar to the flora, like the mid flora, or is it?
I'll show you. So over here, this is the cecum, right? We were talking about. What connects to the cecum? Right, and the terminal ileum, right? And you can't quite tell which of these two pieces of small intestine has the terminal ileum, but I think it's this one.
Hang on, let me just fill out.
Okay, because you can see it connect there, and it goes back. Okay. So, what else comes off of the cecum?
Appendix.
Follow the arrow.
It's a little light.
What is that?
Appendix.
So you see, here's the colon. Here's the little fecalith, okay, or an appendicolith in this case, and here it keeps keeps going and going and going, and it's a blind band. It stops. Right? So what is that? It is the appendix. And this haziness in the fat, see how normal fat, normal fat, normal fat, normal fat. But then here, this fat around the appendix is very hazy and a brighter gray than this fat is. Okay? And by the way, what is this muscle? That's right. And what is this? Perfect. Okay. So, what is this? This is all inflammation around this appendix, which is causing appendicitis. Okay.
It's the guy that just left because I locked him out. I locked him in, I should say.
So this is the appendix with inflammation around it. You've got appendicitis. And you can see how this is irritating your psoas here.
I didn't see that.
Well, I mean, just see the inflammation is just right on the psoas. Right? So what would be a positive test in a patient like this? Likely a psoas. Right? That's a good indicator of a retrocecal appendix. An appendix that's sitting behind the cecum in the retroperitoneum, as opposed to a free peritoneal appendix, okay, which tends to have more of a Robson's and an obturator's on the non-psoas. Okay.
What percentage of patients have each, would you say?
I don't really know. So the retrocecal appendix is less common, but it's not that rare. Maybe 30%.
The cecolith was the number one cause of appendicitis in adults or something? Or was it, there's
Not
something in
particularly.
kids versus adults.
In kids. But it's associated with recurrences that it's not particularly good. So that's signs of appendicitis. And you can see, so if you had diverticulitis, you would see the same kind of inflammatory changes around the sigmoid. So those are the inflammatory changes, what they call fat stranding. There's a stranding of the fat, or haziness. Okay. Those are all indicators of inflammation.
Is there a difference between fat stranding and fat streaking?
Not particularly.
On a surgical perspective, would you order an MRI or would you just go ahead and take it? If you have a high complex suspicion,
So what would an MRI tell you?
on a CT, would you order a CT or would you
For a patient with appendicitis? I believe appendicitis is a clinical diagnosis. I've always been taught that. So a patient who has a classical presentation of appendicitis
and you can take
generally has appendicitis, and your diagnostic accuracy can be more than 85% accurate, then you should just operate. If you have a presentation that's unclear, then you get imaging. That's generally how it works. If you're concerned about an abscess for FAPI that's now formed an abscess, you can get a CT scan because you treat those differently as well. If you come down here, he's going to look for the ureters, but you can't really see them. Okay, let's go up and see. He doesn't have contrast, so it's hard to see, but what's this still? That's the aorta, abdominal aorta, descending, and this is? Good. I'm going to keep going down. Now you see it split into two. Yeah, left and right, common iliacs. And the left and right iliac veins, also known as the innominate veins. Which is funny because the word innominate means unnamed. So it's named the unnamed vein that has a name that's known as the iliac. So I don't know where that came from. And you can see that common iliac then splits, and it gives you the internal and external iliacs. So here's the external, right, and the internal goes back here. It's a little harder to see without contrast, but it's coming here. Okay? So now, here, you get to the groin, you see fat bulging through like this, and that's early, small, inguinal hernia forming, or a cord lipoma. It's hard to tell. Okay, and the reason it's hard to tell is because you can't tell that fat in the inguinal canal if it's intraperitoneal fat or preperitoneal fat. Because preperitoneal fat would be a cord lipoma, and intraperitoneal fat would be a hernia. You can't tell because you can't see the peritoneum. The peritoneum is so thin you can't see it. So unless there's bowel down there, you wouldn't know on a CT scan if it's truly a hernia or not. But if it's a big giant thing, then you kind of know. With that said, I think he's got a right side inguinal hernia. Now, if you go further, you can see this, the vessels here then cross through this, right? And then maybe change names. So what is this called now?
Deep femoral? No, common
Femoral artery, right? And then you go a little further, and you've got, that's as far as it goes, but you can see it split here and here. It's trying to split up. So this is the bifurcation of the
common one to deep and superficial femoral.
superficial femoral and profunda femoris.
Profunda is the deep one?
Deep femoral and profunda femoris. Okay?
Romero. Well,
This is
start from the back and come from the top of the vision. From the back. Yeah, I'm going to grab my piece and close the door.
Be careful. Yes, yes.
so if you look at this, you can kind of see this vessel go right here. Where do you think that is? It's really more in the abdominal wall.
Oh, that's the testicular artery?
It's the epigastric. Goes up. There's the belly.
It's the residual form they're called. It's the residual, they're not functional anymore, right?
No, you're thinking of the. You're thinking of the urachal remnants.
Yeah.
No, this is not that. So if you look here, off of your femoral, you will have a vessel that comes up behind here, right there, and that's your internal, inferior epigastric vessels run along the backside of the rectus there. Make sense? So medial to that is your ocelot's triangle. Okay. What is, since this guy's muscles are so well defined, he's actually a pretty fit guy. What are these three structures?
Minimus, gluteus.
They're all gluteus. Minimus, medius, maximus. Good. So those are the glutes, well formed. And what is this structure here? Okay, what's this?
Yeah.
And now it's the iliosome. Okay. Because they form, they fuse, right? And this is what? Paraspinal, that's right. So you're behind. So this is the vertebral body of the lumbar. This is the spinous process. There's your transverse processes.
James, do you think you can back him up? You feel comfortable?
Yeah, I can do that.
This is the spinal canal. Vertebral. Okay, you've got vertebral column right here. So your spine, spinal cord is right here. And if you go way down to the sacrum, you see it splits into chordae tendon and stuff. Okay. So So what is this? Cilia, right? And
Well, I'm sorry, I missed what the other two. You said they weren't the rectal. What were they?
oh, I was showing you the inferior upper gastric artery over here.
Oh, okay. Yeah. So that climbs back up from the profundus
It comes up off of the
or the common.
off of the femoral or iliac, right at the inguinal ligament, and it comes back,
Yeah.
up to meet the superior. Okay, what's this? Femoral head. So here's some. This is a landmark Dr. Ben-Zur uses when he's trying to do angioplasty. How do you find the femoral artery if it's calcified? You can't feel the pulse. Or how do you find the vein, right? So if you go straight down to the femoral head, middle of the femoral head, you're usually right on top of the artery. So when he's in there using fluoroscopy, that's what he's doing. The other way to find it is usually 2 centimeters medial to the pubic tubercle is your femoral vein.
2 centimeters.
The lateral portion of the.
What did you say? 2
Yeah.
centimeters long.
Okay, so you go on the thigh, 2 centimeters from the pubis. That's the vein right there. So that's a good landmark for trauma patient. Or a code. Patient who's hypotensive or coding, they have no palpable pulse. How do you find the artery? The way most people find the vein is they find the artery by feeling the pulse. And which side of the pulse should the vein be?
Lateral.
Medial. Right? So if you feel the artery and you stick a needle medial to your finger, you're going to be in the vein, usually. But if you can't feel the artery, then you find the vein. Anatomic landmarks. You can't necessarily feel the femoral head, and if you're in an emergency room setting, you just aim for the vein here. If you hit the artery, you're going to have an A-line. Sometimes you need to do that. Sometimes you need an A-line. You need an A-line, and you're in a patient that's very poor blood pressure, and you need to get an arterial access to get an ABG, or you need arterial access to monitor their blood pressure because you're putting them on compressors, but you can't get one in their arms for some reason. Okay. But a femoral vein you get for central venous access. Okay. So remember, the progress is always nerve, from lateral to medial, nerve, artery, vein, so sciatic nerve, femoral artery, femoral vein, empty space, and lymphatics. That empty space is the femoral space, or space of unity. That's where the femoral hernias go. So if you look there, medial to the vein, and you see bowel, you're like, well, that's a femoral hernia. Not a normal finding. You should just see a little bit of fat. Okay. And what are these?
That's the. No, that's the.
Yes.
Yes.
Spermatic cord, testicular vessels. Right. Okay. So very well defined musculature here, you can see. Right?
So used to seeing the flattened.
Flat, thin, no muscle.
Yeah.
Yes.
No,
This is what happens when you exercise and take care of yourself.
How old is it?
This is a 55-year-old male. As you've seen.
You get the size that lady is.
You can get appendicitis at any age, in anyone. And lastly, what is this structure here? Yes, and this is,
That's the rectum.
okay, what is this?
That's the xiphoid. Not xiphoid. The coccyx.
Coccyx, good. And what is this?
Prostate.
Yes, nice and large prostate.
Relax. We'll try to figure out something that works. Okay.
What's the typical?
We'll have to have this
how do you know
on.
whether or not it's large or
It's not on.
yes?
Well, you can measure it and get the volume and stuff. This just looks bigger than I'm used to seeing a little bit. It looks like computer. It's very homogeneous and stuff, but it's a little bigger than most. And these are your pelvic floor muscles, so your ischiopubis, and you got your puborectalis, and your coccygeal. All of these help with pelvic floor function and continence. That's how you hold it. This is also these rectal sling or puborectalis sling is the reason that people poop better when they squat rather than standing or sitting.
Why is that?
Because in the squatting position, the sling relaxes to straighten out the rectum and allow it to open. And in a more upright position, the sling pulls forward and helps create an angle by the sphincter to give you more tightness and continence.
Is the sling, what muscles are
The puborectalis. So it comes from the pubis, goes around the rectum.
So,
Like a little.
some medical patients that had they would just get frequent rectal prolapses. Is that because you get
So rectal prolapse is a weakening of the pelvic floor. And what happens is essentially from rectal penetration or childbirth, we'll do it, anything going through the pelvic floor can stretch out the pelvic floor. And so things can prolapse out. And yeah, if you've stretched out the rectal sphincter complex and the whole pelvic floor enough where the muscles are dysfunctional, then the rectum itself isn't being held up by anything. Because the pelvic floor has no bones. It's a big ring, right? And the floor of the pelvis is a bunch of muscles. And if those muscles are stretched and weakened, then the ligaments are damaged, then everything just falls out. And that's a problem.
Is there corrective surgery for that?
There is a corrective surgery for rectal prolapse, but it doesn't correct the underlying problem because you can't make the muscle stronger. So what you do is you shorten the amount of bowel that they have through prolapse.
I see.
So you essentially do some form of prostatectomy, or you can do a procedure where you pull the rectum up into the pelvis and suture it to the sacrum to keep it from prolapsing with some mesh sling or some kind of thing to hold it up, so that you can't strengthen the pelvic floor, but it can hold things up inside. Or the other procedure is, which is done on older patients, is if whatever's prolapsed, you just amputate and sew the edges together so that whatever's prolapsed is.
I've got it recorded. So.
Whatever's prolapsed, you just can take out essentially, and that way there's less redundancy, and you're relying on the mesentery and vessels to hold the rest up from prolapse. We were going over the pelvic floor.
In terms of, you said the
Let's do questions.
Sling.
I'm going to pause this.